Hello everyone, I am myself Dr. Rajesh Gubba. I am the General Medicine Educator. In this session, I'll be discussing a very important form of vasculitis, that is the polyarteritis nodosa. So polyarteritis nodosa, it is a medium vessel vasculitis. Right? It is a medium vessel vasculitis. And you have to know that which vessels are affected in these patients with the polyarteritis nodosa. So it is mainly the medium sized vessels, that is the vessels which are supplying to the skin, the vessels which are supplying to the GIT, that is gastrointestinal tract, that is mesenteric vessels. Right, that is mesenteric vessels. So the vessels supplying to the kidney, that is the renal arteries, are also affected, and vessels supplying to the heart and vessels supplying to the brain are being affected. So another very important question is that in patients with polyarteritis nodosa, which is a medium vessel vasculitis, the organs which are not involved is lungs. Right, the organs which are not involved is lungs. Okay, lungs are spared. Right, that is a very important point in the polyarteritis nodosa. And what are the common features in patients with polyarteritis nodosa? That includes the development of fever, right, and development of abdominal pain. Why is that? That is because of inflammation of the mesenteric vessels supplying the GIT, and there can be pain within the extremity, right? There will be extremity pain, right? Skin manifestation, and that skin manifestation is in the form of livedo reticularis, right? That is in the form of livedo reticularis, that is the abnormality within the skin. And next, mononeuritis multiplex. Okay, so I'll discuss in detail about these manifestations in patients with the polyarteritis nodosa. But these are the common features the individual will have. And even there is also involvement of kidney. Okay, so because of the involvement of the kidney, that will cause renin mediated hypertension. Right, that will cause the renin mediated hypertension. So these are the common features that you will see in patients with the polyarteritis nodosa. And you see this clinical scenario, a patient presents with melena, normal renal function, hypertension, and mononeuritis multiplex. What is the probable diagnosis? Polyarteritis nodosa, microscopic polyangiitis, Heenan-Sjölin's purpura, Berger's disease. So the answer in this question is polyarteritis nodosa. Let me tell you, there are two important clues in this question, right, which is favoring the diagnosis of polyarteritis nodosa. Now, what are those two important clues? Number one, the absence of lung involvement. Right, so lungs are spared in patients with polyarteritis nodosa. Okay, absence of the lung involvement, and there is hypertension, right? There is hypertension along with normal renal function. Right, there is hypertension along with normal renal function. So these two are the important clues in this question which favors the diagnosis of the polyarteritis nodosa. So this hypertension without glomerulonephritis, right? Hypertension without glomerulonephritis. right? Hypertension without glomerulonephritis along with other features of vasculitis that will suggest the polyarteritis nodosa, okay? And the other two symptoms mentioned in the question, that is melena and mononeuritis multiplex, right? Melena and as well as mononeuritis multiplex. They are also commonly seen in patients with the polyarteritis nodosa, right? And when you are using this word mononeuritis multiplex, and at the same time you should be very much clear with what are the most commonly involved nerves in patients with the polyarteritis nodosa. So the most commonly involved nerves in polyarteritis nodosa is the sural nerve, then involvement of the peroneal nerve, radial nerve, and as well as the involvement of the ulnar nerve. So these are the nerves which are most commonly involved nerves in patients with the polyarteritis nodosa. And you take the other options. The other options was like microscopic polyangiitis, Henon-Schollen's purpura, and as well as the Burgers disease. So if you take this microscopic polyangiitis, lung involvement is common. But in our question, lung involvement was not there. So your microscopic polyangiitis is ruled out. And in Henon-Schollen's purpura, there will be deterioration of the renal function. Why? Because in Henon-Schollen's purpura, you have the development of glomerulonephritis. But our question says the normal renal function. So that will rule out your Henon-Schollen's purpura. And you take in case of Burgers disease, which is also a medium vessel vasculitis, the most common presentation is the presence of severe digital ischemia. Right? Is the presence of severe digital ischemia without evidence of the internal organ involvement, right? There is no internal organ involvement, okay? But the most common presentation will be the severe digital ischemia. That is what you will observe in patients with the polyarteritis nodosa, okay? So if you see this question again, in polyarteritis nodosa, aneurysm are seen in all except kidney, lung, liver, pancreas. So we have discussed just now that lung involvement will not be there in patients with the polyarteritis nodosa. So if you see all the organ systems which are affected, right, among all the organ systems, let me tell you, it is the musculoskeletal system which is most commonly affected. Right, musculoskeletal involvement, it is seen in almost 64% of patients. Then followed by that, there will be involvement of the renal artery in almost 60% of patients. Then involvement of peripheral nervous system, right? Involvement of GIT, that is gastrointestinal tract. There is involvement of skin, involvement of the cardiovascular system. Next, involvement of genitourinary tract. And lastly, central nervous system. Okay, so these are the other organ systems which are particularly involved, right? But among all those, musculoskeletal involvement is very common, right? It is seen in almost 64% of patients. Now, in patients with polyarteritis nodosa, what is the muscle biopsy picture? Right, in patients with polyarteritis nodosa, muscle biopsy, what does it show? Necrotizing arteritis, atrophy, granulomatous lesion, and the presence of the ring lesions. So, in patients with polyarteritis nodosa, let me tell you, it is characterized by necrotizing inflammation. Right, the type of inflammation is necrotizing inflammation. And the vessels which are commonly affected is, right, the vessels which are commonly affected is the medium sized vessels, right? And small vessel involvement will not be there in patients with polyarteritis nodosa. That means there is no involvement of your arterioles, there is no involvement of your venules, there is no involvement of the capillaries, where in patients with the polyarteritis nodosa. Okay, and this polyarteritis nodosa, it can involve virtually any organ with exception of the lung, right? Lung involvement will not be there. Okay, and there will be renal artery involvement, but glomerulonephritis will not be there. This is another point that you should know. So there is involvement of renal artery, but there is no glomerulonephritis. Right, there is no glomerulonephritis. So because of the involvement of the renal artery, the individual can develop, or the individual can have activation of the RAS, that is renin angiotensin aldosterone system, and because of which there is development of hypertension. Right, because of which there is development of the hypertension. And as we have discussed in all other forms of vasculitis, you have the presence of the constitutional symptoms. Even in patients with polyarteritis nodosa also, the constitutional symptoms are common. That includes fever, malaise, weight loss, and as well as the myalgia. Now, after having discussed about the basic introductory points related to your polyarteritis nodosa, now let me discuss, or let me tell you what will happen because of the involvement of the individual organs. Now, you take the vasculitis of the skin. Because of the vasculitis of the skin, there will be livedo reticularis. So livedo reticularis is diffuse distribution over the extremities and buttocks. So right, livedo reticularis is very common, right? It is diffuse distribution over the, right? So you can see this is your livedo reticularis, right? That is a diffuse distribution over the extremities and as well as the buttocks. Then followed by this livedo reticularis, the next important thing is nodules, papules and ulcers. Right, nodules, papules and ulcers. That is another form of the skin involvement in polyarteritis nodosa. And even these nodules, papules and as well as ulcers, they frequently involve the lower extremities. Right, they frequently involve the extremities of the lower limb. Right, and the digital ischemia will be there. So digital ischemia leading to gangrene. Right, digital ischemia leading to gangrene is another very important clinical manifestation. And within the nails, the individual will have the presence of splinter hemorrhages. Right, there will be presence of the splinter hemorrhages. Okay, and there can be also presence of palpable purpura. And this palpable purpura, right, this palpable purpura, it is distributed or concentrated over the buttocks and as well as the lower limbs. Right, over the buttocks and as well as the lower limbs. So that is about the skin involvement. And let me tell you, the most common skin involvement will be the livedo reticularis. And most of the skin involvement is mainly seen within the lower extremities and as well as the buttocks. And you take, due to vasculitis of the peripheral nerves, right, due to vasculitis of the peripheral nerves, mononeuritis multiplex is very common. Right, mononeuritis multiplex is common, right, where there is involvement of the sural nerve, right, where there is involvement of the peroneal nerve, right, where there is involvement of the radial nerve, right, where there is involvement of the ulnar nerve. Okay, so common manifestation, which one? The mononeuritis multiplex, common manifestation, and it is seen up to 60% of cases. Right, it is seen up to 60% of cases, and it is asymmetrical mononeuritis multiplex. right? It is asymmetrical mononeuritis multiplex. Okay. Next, then followed by that, what will be the features due to vasculitis of the gastrointestinal tract? See, due to vasculitis of the gastrointestinal tract, that is mesenteric vessels, the individual will have abdominal pain. Right? The individual will have the abdominal pain. Okay. So, why is this particular abdominal pain, or when is this abdominal pain? Mesenteric vessels are the vessels which are supplied to your GAT, and because of the inflammation of these mesenteric vessels, the blood supply to the GAT will be reduced, and where the individual will have abdominal pain, and that we call it as, right? And when is the time of this particular abdominal pain? It is immediately after taking the food, because immediately after the taking the food, the GAT requires more blood supply, and in mesenteric vasculitis, the blood supply to the GAT is compromised. So there will be a mismatch. Demand is more, supply is less. So there will be a postprandial abdominal pain. Right? This we also call it as the intestinal angina. Right? This we also call it as the intestinal angina, is very common. And apart from that, the gastrointestinal bleeding is more common. Right? Apart from that, the gastrointestinal bleeding, and this gastrointestinal bleeding, right, it is present as the melena. Right? Melena may be the presenting symptom. So that will be your the vasculitis of gastrointestinal tract presentation. Because of the vasculitis of the renal artery, that is renal vasculitis, the individual will develop renovascular hypertension. Right? The individual will develop renovascular hypertension. And please remember, glomerular vessels are not involved. Right? Glomerular vessels, they are not involved. Okay. So that is the reason why there is no glomerulonephritis. Right? That is the reason why there is no glomerulonephritis, and there is no RBC in urine. Right? There is no RBC in the urine. And what are the other features of vasculitis? Right? There will be joint involvement. Okay. And this joint involvement, let me tell you, mainly the large joints are affected. Right? Mainly the large joints are affected. And these particular large joints which are affected include knee, ankle, and as well as the elbow. Right? Knee, ankle, and as well as the elbow. So these are the joints which are commonly affected in these patients with the polyarteritis nodosa. And in patients with polyarteritis nodosa, let me tell you, there is also involvement of the cardiovascular system. And this cardiac involvement, right, this cardiac involvement will be in the form of the congestive heart failure, or in the form of the myocardial infarction, or even in the form of the pericarditis. Right? So this will be the cardiac involvement in patients with the polyarteritis nodosa. But these are rare manifestations, and there can be also involvement of the central nervous system. Central nervous system involvement will be in the form of cerebrovascular accidents. There can be development of seizures, and altered mental status may occur. Right? Altered mental status may occur. And followed by that, the genitourinary involvement. And this genitourinary involvement will be in the form of testicular and epididymal pain in males, okay, and ovarian pain in females. Right, ovarian pain in females. So that will be the genitourinary involvement, right? So these are all like multiple systems which are affected in patients with the polyarteritis nodosa. And let me tell you that there is also viral association in polyarteritis nodosa, and that particular viral association is the hepatitis B. So hepatitis B is an established etiological agent and association for polyarteritis nodosa. So that is the reason why this hepatitis B serology should be done in cases of, right, should be done in cases of the polyarteritis nodosa. And what will be the serology? That is surface antigen, right? And then followed by that even the antibodies, that is IgM, anti-HBC, next IgG, anti-HBC, right? And then followed by that the presence of anti-IgE. Okay, so you have to test for HBV DNA levels. So these are the serology that you have to search in patients with the polyarteritis nodosa regarding your hepatitis B. So to summarize all the manifestations, right, this is the summary. So Livedo reticularis is the skin manifestation. There can be nodules and papules, ulcers in the lower limbs, digital ischemia leading to the development of gangrene, and there can be palpable purpura. Vasculitis of the peripheral nerves where there is mononeuritis multiplex, which is very common, right? And vasculitis of the gastrointestinal tract where there is mesenteric vasculitis due to which there is abdominal pain and gastrointestinal bleeding. And vasculitis of the renal artery where there is renal vasculitis causing renovascular hypertension. And other features of vasculitis include joint, cardiac, CNS, and as well as the genitourinary involvement, right? So if you take the skin involvement, as I have mentioned, the most common cutaneous manifestation, right, most common cutaneous manifestation will be in the form of Livedo reticularis, right? That will be in the form of Livedo reticularis, and they are most commonly seen over the lower limbs. They are most commonly seen over the lower limbs. Now, after having discussed about the clinical manifestations, let me discuss about the laboratory findings. Most patients with polyarteritis nodosa, they have slight anemia, right? There is slight anemia, and right, and the leukocytosis is common. And apart from that, because it's an inflammatory disorder, acute phase reactants are often strikingly elevated. It is not always, right, but very frequently these acute phase reactants, they are often elevated, right? And a major challenge in making the diagnosis of polyarteritis nodosa, however, in the absence of disease specific serological test, that is an autoantibody. Okay, so these are the laboratory diagnosis. There is slight anemia, leukocytosis, and acute phase reactant, that is ESR and CRP, right? ESR and CRP, it is elevated. And what about ANCA, right? What about ANCA? So let me tell you, it is an ANCA-negative vasculitis, right? It is an ANCA-negative vasculitis, okay? And but these individuals with polyarteritis nodosa, they may have low titers of rheumatoid factor or anti-nuclear antibody, okay? So they can have low titers of RA factor and anti-nuclear antibody, but both of them, they are non-specific, right? Both of them, they are non-specific findings. And as already I have mentioned, that you have to do the testing for hepatitis B serology. Right, you have to do testing for the hepatitis B serology, right? And what is that? As I have mentioned, surface antigen, then envelope antigen. Presence of the envelope antigen tells you about the infectivity, okay? And you have to do the HBV DNA levels. That will tell you about the viral load. This should be performed, right? So that is about the laboratory findings. But apart from that, biopsy and as well as the angiography. The diagnosis of polyarteritis nodosa requires confirmation with either a tissue biopsy or an angiogram. So this biopsy and angiogram or angiography, this will confirm the diagnosis. Right, confirmation of the diagnosis. And biopsies of symptomatic sites should be done, right? So where is it you want to take the biopsy from? The biopsy has to be taken from skin. That is exactly wherever the ulcer is there, from the edge of the ulcer you have to take. Okay, so you have to take the biopsy from edge of the ulcer, or if there is like a nodule, you have to take a biopsy from the center of the nodule. So wherever is the affected site, there you have to take this particular biopsy, right? And the other sites where you can take the biopsy is within the nerve or muscle, right? Within the nerve or muscle. See, when you are taking the biopsies from the affected sites, that is skin, nerve or muscle, they have sensitivities of approximately 70%, right? Up to 70%, okay? And the least invasive test should usually be obtained first, but biopsy of an involved organ is very much essential. So biopsy and as well as the angiography, that will give you the confirmation of the diagnosis, right? That will give you confirmation of the diagnosis, okay? Right, so this is about your diagnosis. Then followed by that, how do you treat these patients? So in patients with polyarteritis nodosa, corticosteroids in high doses may control the fever, may control the constitutional symptoms, may control or may heal the vascular lesions. So the treatment is high dose corticosteroids, okay? So you have to give almost 60 milligrams of oral prednisolone, right? You have to give almost 60 milligrams of the oral prednisolone daily. So when you do that, this will control the fever, right? This will also control the constitutional symptoms, right? This will control the constitutional symptoms. Now apart from that, pulse methylprednisolone, that is 1 gram intravenous daily for 3 days, that is necessary for patients who are critically ill, right? So in individuals who are critically ill, they require pulse methylprednisolone. So wherein you need to give 1 gram of methylprednisolone, right? That has to be given for nearly around 3 days, right? And along with this, the addition of cyclophosphamide, right? The addition of the cyclophosphamide will reduce the risk of disease related death. Okay, so will reduce. So when you add cyclophosphamide, there is decrease in the mortality, and there is also decrease in the morbidity, right? There is decrease in mortality, and there is also decrease in the morbidity among patients who have the severe disease. So that is about the treatment in patients with the polyarteritis nodosa. Now, apart from these steroids and cyclophosphamide, whenever they, or in order to maintain the remissions, right? So in order to maintain the remission, the drugs that you need to give is methotrexate or azathioprine. Right? Methotrexate or azathioprine are used to maintain the remissions. That is very important. Now, for patients with polyarteritis nodosa associated with hepatitis B, the preferred treatment regimen is a short course of prednisolone accompanied by anti-HBV therapy. Okay, so for suppose, the development of polyarteritis nodosa, if it is secondary to hepatitis B, then in these patients, you need to give the short course of prednisolone. Right, this should be given along with the anti-HBV therapy. Right, this should be given along with the anti-HBV therapy and plasmapheresis. So plasmapheresis will remove the antibodies which are present within the serum or the plasma. And the other point is the inhibitors of tumor necrosis factor, that is inhibitors of TNF, they are the first line therapy for patients with polyarteritis nodosa associated with deficiency of adenosine deaminase 2. So if it is secondary to hepatitis B serology, or if it is secondary to hepatitis B virus, along with prednisolone you need to give anti-HBV therapy. But if this polyarteritis nodosa, if it is due to deficiency of adenosine deaminase 2, in this case, right, in this case you need to give inhibitors of the TNF. So inhibitors of the TNF, that will be the first line therapy or the first line treatment for polyarteritis nodosa associated with deficiency of adenosine deaminase 2. And overall, how is the prognosis of these patients with polyarteritis nodosa? Without treatment, 5-year survival rate in this disorder is about 10%. Right? Without treatment, 5-year survival, right, it is up to 10%. Whereas with appropriate therapy, right, with appropriate treatment, remissions are possible in many cases. Right, remissions, they are possible in many cases. And 5-year survival rate, right, 5-year survival rate in case of polyarteritis nodosa with appropriate therapy has been improved to 60 to 90%. Right, appropriate therapy means mainly your high dose corticosteroids, right, and in severe cases you also need to add cyclophosphamide. Right, then what will be the poor prognostic factors? Right, so poor prognostic factors include the presence of the chronic kidney disease with serum creatinine greater than 1.6. Right, with serum creatinine greater than 1.6 milligrams per deciliter. Right, next, proteinuria. proteinuria greater than 1 gram per day, right? Proteinuria greater than more than 1 gram per day, then development of gastrointestinal ischemia, right? And that is secondary to mesenteric vasculitis, right? And involvement of central nervous system or the cardiac involvement. These are the poor prognostic factors in patients with the polyarteritis nodosa, right? And in the absence of these 5 factors, right? That means there is no cardiac involvement, right? And there is no CNS involvement. There is no chronic kidney disease. There is no proteinuria, or there is no gastrointestinal ischemia. So in the absence of these 5 factors, 5-year survival rate is nearly 90%. Right? 5-year survival rate is up to 90%. When there is no kidney involvement, when there is no proteinuria, when there is no cardiac involvement, when there is no CNS involvement, in them the 5-year survival rate is up to 90%. Okay. So with the treatment, the prognosis or the morbidity can be reduced. Morbidity and as well as mortality can be reduced in these patients with the polyarteritis nodosa. So to summarize this topic of polyarteritis nodosa, let me tell you, constitutional symptoms are very common. That is fever, malaise, weight loss and myalgia. Skin involvement, that is livedo reticularis, is the most common skin involvement. And apart from that, nodules, ulcerations, digital ischemia leading to gangrene. And there will be also joint involvement, that to large joints, that is knee, elbow, ankle and as well as the wrist. Then followed by that, there is also vasculitis of the peripheral nerves resulting in mononeuritis multiplex, and vasculitis of the mesenteric vessels, right, resulting in mesenteric vasculitis, where the individual will have intestinal angina or postprandial abdominal pain. And kidney involvement, right, there is vasculitis of the renal artery, but renal parenchyma is absolutely normal. There is no glomerulonephritis at all, right? So the intraparenchymal renal inflammation is common and hypertension is being present. And the cardiac involvement, if you see, patchy necrosis of the myocardium is seen, right? Patchy necrosis of the myocardium is seen. So this is like multi-system involvement, and in patients with polyarteritis nodosa, let me tell you, there is no lung involvement. And the investigations, if you take the complete blood picture, there will be normocytic normochromic type of anemia, mild to moderate leukocytosis, and there is pronounced thrombocytosis. There is increase in the platelet count, right? And renal artery involvement is common, right, due to which there is renovascular hypertension. And urine analysis will show you the presence of the proteinuria. There can be hematuria, but there is absence of the RBC cast, right? That is very, very important in patients with the polyarteritis nodosa. And if you see the acute phase reactants, that is ESR and CRP, they are elevated. And it is an ANCA-negative vasculitis. And hepatitis B, it causes the development of polyarteritis nodosa in minority of the cases. And there is sparing of the lung. That is why if you do a chest x-ray, you will have an absolutely normal chest x-ray. And treatment is your high-dose corticosteroids. And in order to maintain the remissions, you need to give the methotrexate, or even the azathioprine can be given. Right? So let me just show you some important multiple choice questions on the same topic. So muscle biopsy in polyarteritis nodosa is what? It is necrotizing arthritis. It is necrotizing arthritis. Okay. Next, a patient with melena, normal renal function, hypertension, mononeuritis multiplex, the probable diagnosis is polyarteritis nodosa. Right? The same question, right, I have taught you. So this completes the discussion of this very important topic, that is polyarteritis nodosa. Thank you very much.